Well, thank you very much for asking us to speak about this area and to contribute to this important meeting. Over the next few minutes, Kathy, Lou and myself are going to just basically take you through some of the following things. First of all, that the licensed treatments that we have for agitation are based largely on sedation and carry significant risks, that symptoms of agitation can be evanescent, and together with the large placebo effects involved in the studies, this mounts huge challenges for trying to show that a drug is superior to placebo, that the broadness of symptoms involved in agitation and choice of the outcome measures that are needed to capture change and convince prescribers are incredibly important in this area. Kathy's going to talk a little bit about current phase 3 trials and how they're investigating novel and repurposed agents for treatment, and about how emerging mechanistic clues in agitation could inform targeted drug development. So risperidone is the drug that has a license in the EU for the treatment of agitation and aggression in the short term in people with dementia. It's really important to remember that the data on which that license is based is now more than 20 years old, comes from a trial published in Neurology in 1999, and that the actual discovery that it was the aggressiveness cluster of symptoms that seemed to respond more strongly to risperidone than placebo was a post hoc analysis. If you look at this graph, this is the main outcome data from this study. The panel on the left shows you the overall BEHAVE-AD score over the 12 weeks of the study. You should be able to see 3 curves, one for placebo, one for risperidone, and one for haloperidol. Janssen, who did the trial, were very keen, I think, to show that risperidone was superior to haloperidol, both in terms of its efficacy and side effect profile. But if you look at the panel on the left, what I hope you can see is that in all 3 groups, the BEHAVE-AD score improved over the 12 weeks, regardless of treatment. And when I show this data to people, I often say to them, what I think you should conclude from this is that placebo is a very, very good treatment for improving BEHAVE-AD score. However, the panel on the right shows results of a post hoc analysis that Janssen carried out, where they looked specifically at the aggressiveness cluster symptoms from BEHAVE-AD. And I hope you can see they found a more convincing separation between drug and placebo, although interestingly, the haloperidol didn't show any separation from placebo. But this data, poor as it is, and the fact this is a post hoc analysis needs to be borne in mind, essentially formed the backbone of the license application, and it's being given for risperidone to treat aggressive, agitated behaviour in the short term for 6 to 12 weeks in people with dementia. And this is important because risperidone, it turns out, is quite a dangerous treatment for people with dementia to take, and clinicians who are faced with a patient with agitated behaviour need to do a very careful balancing of the risks and benefits in using that treatment against the risks of not treating. Sometimes it's very dangerous not to treat agitated aggressive behaviour with dementia. But if I can just show you a couple of pieces of data that are perhaps pertinent to our thoughts on this. The first is, so we reported a year and a half ago that the use of antipsychotic people with dementia had actually increased during COVID-19. This isn't surprising because if you think about the impact that lockdown and people not being able to visit their loved ones in care homes would have had upon people with dementia, it's unsurprising that more antipsychotic drugs were used to treat that behaviour. If you look at the panel on the left, you can see a number of coloured lines, and what they show is the proportion of people on the Department of Health's dementia register who are also prescribed an antipsychotic drug. So the Department of Health collects monthly data on the use of antipsychotic drugs in people with dementia. What I hope you can see is the green and red lines, which come from 2018, 2019, show there's a fairly steady rate of between 9.2 and 9.4% of people with dementia who are prescribed antipsychotics. If you look at the purple line, it shows you what happened during 2020 when the pandemic hit. And what I hope you can see is a fairly dramatic increase to about 10%, and then a falling away. And that falling away, we think, is because of the large number of people with dementia in care homes who died during that phase of the pandemic. But you see that purple line then rose back up again to over 10%, and the yellow line shows the data that we have from 2021, which shows that that increase in the use of antipsychotics was maintained and has continued to be maintained. Now, what this actually only shows is the number of people prescribed antipsychotic. It doesn't show the people who were already on antipsychotic who had the dose increased, but it's pretty good evidence, I think, that antipsychotic use increases when the care for people with dementia becomes difficult. And this is important because if you look at the panel on the right, what that shows is the risks associated with using antipsychotics in dementia. And what that figure shows you is the number of people that need to be treated with antipsychotic, people with dementia, to cause an attributable death. And what you'll see is that for haloperidol and risperidone, it's about 26 or 27. And that's a very chilling statistic for a clinician who treats people with dementia and agitation, to think that for every 26 or 27 people that I've treated, I may have caused an additional death that wouldn't have happened without that treatment. Of course, when I spoke about balancing the risks, it's really important to remember that not treating agitation and aggression can also lead to death in people with dementia. But you get a feeling for how complicated and difficult that risk-benefit calculation is for clinicians. So we don't really want to have to use antipsychotics in people with dementia, but I'm afraid the search so far for what seem like sensible alternative treatments has been pretty fruitless. I show these two figures. These two figures are the primary outcomes from two trials. As you can see, they were conducted sort of several years apart. And these are both independent trials carried out by UK investigators. They both use the Cohen-Mansfield agitation inventory as their primary outcome. And the CMAI is very much a kind of like a ragbag collection of agitation symptoms, but it's often used as an outcome measure in trials. It has good sort of face validity and it's a reliable measure. But in both of these trials, you can see the effect of drug and placebo. It's not significantly different. Both cholinesterase inhibitors and sedating antidepressants, such as mirtazapine, are often used by clinicians to treat agitation. And it's always very disappointing when a trial shows that one's clinician's favourite treatment for indication is actually no better than placebo. It's also really important when you're designing a trial that clinicians can have a sense of what a change in the primary outcome means. So the Cohen-Mansfield inventory, many clinicians will know about the items of that and will have a kind of feeling for what a change in it means. The citalopram for agitation Alzheimer's disease is a really important study that was published in JAMA 7 years ago. And what's remarkable about this study is that it actually showed a significant benefit of drug over placebo in the treatment of agitation, using a common drug that many of us prescribe, but hasn't really achieved any kind of clinical cut through, in that clinicians don't use citalopram to treat agitation. And there are a couple of reasons, I think, for that. The first is that the neurobehavioral rating scale agitation subscale, which is used as the primary outcome, clinicians aren't familiar with that and don't really have a feel for what a significant change on that scale might mean. Maybe if the trialists had used the proportion of patients who showed a civic improvement of agitation, they might have achieved more cut through the results. In fact, 40% of people treated with citalopram, as opposed to 28% with placebo, showed a significant change in their sort of civic rated agitation. And the trial also reported adverse effects. So 30 milligrams of citalopram is a large dose, much larger than most of us would use in people with dementia. And there was significant QT, interval prolongation, in patients who received that dose, and significant impairment of cognition. So I think the combination of unfamiliarity with the main outcome and concerns about the adverse effects of the high dose citalopram have meant that clinicians haven't used citalopram. There hasn't been the cut through that I think the investigators for this trial expected. So thank you. I'm going to hand over to Kathy now.
Thanks, Rob. So what is the landscape of drug treatment trials in agitation and Alzheimer's disease? We recently conducted a systematic review of 52 registered trials from the clinicaltrials.gov database. And this figure shows the range of drugs investigated for agitation in Alzheimer's disease over the past 25 years. The studies have been arranged according to their start date along the horizontal axis at the bottom and according to their sample size along the vertical axis on the left. And the colours represent the study status, so some studies were active in various stages of recruitment, or they were completed and either published or unpublished, or they were terminated early. So what we can see from this figure is that most studies were of repurposed drugs, and these included antipsychotic medications, which I've circled in red. So you can see in the first half of this time period, many studies were conducted of risperidone and other antipsychotics, followed by newer atypical antipsychotics such as brexpiprazole, lumateperone, and pimavanserin. There were also several studies of SSRI antidepressants such as citalopram, escitalopram, and mirtazapine. There were 3 studies of prazosin, which is an alpha-1 adrenergic receptor blocker, usually prescribed for the treatment of hypertension and PTSD. There were several studies of anti-epileptic medications. And prior to 2010, there were a handful of studies of anti-dementia drugs, memantine and donepezil. In the past decade, we've seen several studies investigating cannabinoids, as well as compounds containing dexmethorphan, which is the main active ingredient in many cough syrups. In the last decade, we've also seen several phase 2 studies of novel agents, which haven't subsequently been taken forwards. And this includes compounds such as this one, ORM12741, which acts on an adrenergic receptor. This was completed in 2017, but remains unpublished. This compound is believed to neutralize amyloid beta aggregation, but missed its primary endpoint in 2015. This compound acts on the glutamate receptor and was terminated early. And this compound also acts on the glutamate receptor, but showed no benefits compared to placebo. So what are the current drugs under investigation in active phase 3 RCTs? So there are 2 phase 3 studies of brexpiprazole currently running. There's one of escitalopram. There's one of nabilone, which is a synthetic cannabinoid. And there are 3 phase 3 studies of dexmethorphan containing compounds. So 2 phase 3 studies, as you can see in the top right corner, of AVP 786 and one of AXS05. The 2 phase 3 studies of AVP 786 follow 2 earlier phase 3 studies of the same drug, which showed conflicting findings. And the phase 3 study of AXS05 follows an earlier positive study, which led to this drug obtaining FDA breakthrough therapy status in 2020. So it remains to be seen how much better or safer these novel and repurposed drugs will be compared to placebo, or what's currently available, which is in the UK, short-term use of risperidone. And it also remains to be seen whether any differences compared to placebo can be interpreted as being clinically meaningful. So do we have any insight into how these drugs under phase 3 trial might compare to placebo or risperidone? So the escitalopram study was based on the findings of the citalopram trial mentioned earlier, because it was suggested that clinical efficacy might be related to a specific structural conformation of the drug, which makes up escitalopram. So we might expect the clinical effects of escitalopram to be similar to citalopram, and the hope is that the side effect profile might be better. For the other drugs under phase 3 study, these are their primary findings from earlier phase 2 or 3 studies, and they all showed favourable quantitative differences compared to placebo. Note that no data was available for AVP 786, so only the 3 drugs here are shown. And they all happen to use the same primary endpoint, which, as mentioned previously, was an agitation scale known as the Cohen-Mansfield Agitation Inventory, or the CMAI. And over periods of between 5 to 12 weeks, there were differences of between 3 to 4 points on this scale versus placebo. And it's interesting to note that this is comparable to the modest effect of atypical antipsychotics of around 3 points on the same scale. And this was reported by a recent Cochrane review. So what this means is that the drug's side effect profile and any clinician-rated global change scores will be important to consider when any findings from these active phase 3 studies are published. So considerations for how to optimize agitation clinical trials have previously been discussed, including in this recent report published in 2020 by O'Gorman and colleagues. And there is general agreement on the importance of investigating potential markers of agitation in Alzheimer's disease, because this could lead to the identification of possible treatment targets. For example, there is some evidence from our work and others that there are measurable differences in autonomic system function, which can be picked up using sensors such as heart rate monitors, as well as specific measurable differences in neurotransmitter systems that can be detected in people who are more likely to go on to develop agitation. So there are emerging mechanistic clues that can guide the development of more targeted therapies in future. So in summary, we've shown why we think that drug development for agitation and Alzheimer's disease is important. We've talked about the background and the issues related to the use of risperidone to treat agitation. We've explained the importance of being able to interpret the primary outcome of clinical trials. And we've discussed the current landscape of drug treatments for agitation and Alzheimer's disease, as well as future drug development strategies. Thank you very much for listening.